everyone. On behalf of West Bengal Doctors Forum, I welcome you all to this unique academic initiative. Having passed through Alpha, Beta, Gamma, Delta, now we are on the 15th letter of Greek alphabet. Whether Omicron is as ominous as Delta is a different question, and that has been quite efficiently dealt with last week by none other than Dr. Sumit Sengupta and Dr. Arjun Dasgupta. Now, while the pregnant women is known to be vulnerable group because of their physiologic adaptations, we have to put extra attention to this particular group and their children. And West Bengal Doctors Forum has quite rightly set an evening for this particular group. And in order to discuss those issues, we have Dr. Indranil Saha, eminent obstetrician of the city. And we have Dr. Soumyakanti Panda, who is currently attached to BC Rai Hospital, a very young, promising, enthusiastic pediatrician with us this evening. And as always, between the obstetrician and the pediatrician sits a fetal medicine specialist, and that's what I will be doing this evening. So without much ado, I will now straight away go on to Dr. Saha, but I will just tell the audience that this is not going to last anything more than 1 hour. And we will be splitting the discussion between the two faculties, two experts rather. And please feel free to post your questions. We will take as many as possible. And just don't hesitate, just ask your questions. Our whole evening will be oriented clinically. It will be clinical scenario-based discussion. So Dr. Saha, if I could straight away go on to you. Now, suppose a 25-year-old, otherwise healthy woman has come to you at 12 weeks gestation, having tested COVID positive. She is otherwise asymptomatic, but she's worried about her fetal health, whether it's going to be abnormal or not. Now, how would you address her concerns? Dr. Saha, please.
Okay, at the beginning, I'll just thanks WBDA for inviting me for this session. Now, as your question, Kanchanda, the thing is, yes, we will address the issue, but before coming to the baby, I will be saying few things about the mom, how healthy the mom is, and what type of medications she is on, and try to reassure her as much as possible. Regarding the worrying of the mother about the teratogenicity of the infection, now there is no evidence that if a mom contact COVID in the first trimester, that there is increased chance of fetal abnormality. And having COVID infection per se is not an indication for medical termination of pregnancy. So we can reassure the mom that as far as data is available, we don't think the baby is at increased risk of any congenital malformations. But to reassure her more, we will be organizing the first trimester screenings, etc., as per protocol.
Yes, I mean, with our experience from rubella and Zika virus and all other RNA viruses, as they can cause severe fetal abnormalities. So there have been significant and legitimate concerns on COVID virus as well. But so far, the data is not supporting that the background incidence of fetal anomaly is as high as to justify termination, as you rightly said. But it will take time. It's too early days. Now, what about the issue of miscarriage? Does it increase the chances of miscarriage?
No, again, with the randomized, with the data which we have, the retrospective and the cohort studies, there is no increased risk of miscarriage following COVID infection. So for that point of view also, you can reassure the mother.
Absolutely, absolutely. Now, Will you recommend home isolation for her and how long?
We will definitely recommend home isolation for her. And if we go by the recent ICMR guideline, we are saying that once she is tested positive, we will be advising her for home isolation for 7 days. And the last 3 days, there shouldn't be any fever. And after that, once the isolation period is over, she can jolly well meet us in the clinic to discuss further about what will be the plan and the management of this pregnancy.
Fantastic. Now, any specific treatment like antibiotics for them?
No, because to be on the safer side, medical legally, we'll definitely refer her to a physician who will be advising her. But if we say about the protocols and what is needed, we don't need any specific antibiotics or antiviral for this patient because this patient is asymptomatic. And even if she develops a fever, we can give her paracetamol 650 or 1 gram, depending on her body weight. Tell her to maintain adequate hydration. If needed, we can give anti-allergics. But what happens, we see a lot that this patient has been prescribed with a lot of medications, which involves azithromycin, which involves ivermectin and hydroxychloroquine. As per as guideline, azithromycin is a FDA category B drug. So it's not absolutely safe, especially in first trimester. We won't be recommending it unless there's a proper indication. Ivermectin is contraindicated in pregnancy, is a category C drug. And regarding the hydroxychloroquine, we know that it's not much effective, but if you someone wants to give it, then we will see the category B drug, and we will to think twice before giving that in first trimester. So
during the second wave, during the second wave, when we were taking phone calls, we were getting a lot of queries on ivermectin. But doctor, I have had ivermectin. Should I terminate this pregnancy? Do you get those phone calls anymore?
No, we are not getting those phone calls. And luckily, what we are seeing in this wave, that patients are complaining of fever, body ache, headache, etc. But we are not seeing any, in my personal experience, whatever small practice I have, I'm not seeing anyone who's getting admitted in the hospital or the saturation is dropping.
Now, I'm moving on to a second scenario now. Suppose someone has come at 25 weeks. She was due for her second COVID vaccine, but in the meanwhile, she has recently tested positive. How will you approach her?
Now, if she's due for a COVID vaccine and if she turns positive, what we'll advise her to wait for 3 to 4 months before she takes a second vaccine. But after that, she should definitely take it because we know the antibody is higher after they have an active infection. So we'll postpone the vaccination for the time being.
I think 12 weeks is the time from the point of recovery from COVID illness that one can have the second dose. But tell me one thing, you do apply a lot of routine vaccinations in pregnancy around that time, around 28 weeks. So how do you space these?
I mean, the routine vaccination which we give during the second trimester, the tetanus toxoid injection and the Tdap, okay? And we don't have much evidence or experience that whether we should be postponing this vaccination just because of COVID infection. But these vaccines can be taken anytime from 24 weeks onwards to around 36 weeks. So if we delay the tetanus toxoid by 3-4 weeks or boost weeks after that, so you won't be harming too much. In fact, if we give this injection close to term, then the amount of antibody which goes to the babies is much more. So delaying this or taking it as per protocol shouldn't be much difference to the patient.
So what is the right time for COVID vaccination in pregnancy?
See, what the government protocol is and what we're suggesting is that you can take COVID vaccine anytime during pregnancy. So there shouldn't be any problem with that. Some patients are a bit worried about taking the vaccine the first trimester. In that case, we do give due respect to their feeling and we say that, yeah, you can delay it if you don't want to take it in the first trimester. But again, if you take it during first trimester, there is not much problem. But definitely we encourage them to take the vaccine as early as possible. Some people, they who are close to the term, I mean, they say 34 weeks, 35 weeks, and they want to take the vaccine, either the first dose or the majority of the second dose now, after delivery. in that case also, we say definitely you can postpone it after for some time, and after delivery you can take the vaccine. So to improve the compliance of taking the vaccine, I think we have to go a bit with the patient's opinion and just not forcing what our idea or what the evidence is, so that the compliance is much better.
Absolutely, absolutely. Now, I'm sure you are getting most of the pregnant women currently who have had already their 2 doses. But how do you tackle someone who is refusing to have COVID vaccine?
No, we do have quite a lot of patients who have only taken 1 dose and they are delaying the second dose. Either they're thinking they will have the infections and have antibody, etc. Now, regarding any vaccine update, I think one thing is that we have to persuade the woman and want to know her concern, why she's not taking the vaccine. Though there is a small thing we have said that joto dosh vaccinated dose. So we know, Jay, because there are varied opinion about the vaccines, so people are worried about it. So we want to address first why she is not taking the vaccine, and if she comes up with reasons, we will be giving reasons to counteract her opinion, and then we'll see the positive side of it. And usually, if the husband or any other family member is against it, we will be wanting to talk to them personally, because a lot of Indian women, the family members has a bigger say than the woman. So we will take that into consideration, and then we'll tell her to take the vaccine, and we'll try to make things as easy for her, getting the appointments, or when to try to get the appointments for her, someone helping her to go into the CoWIN app and get it registered. So if those are the reasons, we will be addressing those.
Now, someone who is having COVID at 25 weeks will also be concerned about premature delivery. What is your take on that?
Now, whatever data we have with premature delivery in COVID, mostly if the infection is the third trimester, there is some increased risk of prematurity, and some studies says that the increased risk of prematurity 15% compared to the background risk of 10%. So it's not that great, and most of the time it is iatrogenic reasons. Doctors are concerned about the welfare of the baby, wellness of the baby, and trying to deliver this baby earlier. So once the patient recover, we can ask her to do a growth scan and Doppler to see how the baby is, and if the baby is absolutely fine, then we can carry on the pregnancy and reassure the mother that nothing is going to wrong.
And regarding data, what I can tell, the background risk of premature delivery for anybody is around 8%. And post-COVID, it is about 12%. So there is an increment in the risk of premature delivery, but we have to individualize those cases. And as you rightly said, we have to manage those circumstances. Now, meanwhile, we are already getting some questions. Some we will plan, we will discuss a little later, like Dr. Kaushik Chaki has asked about breastfeeding. We'll come to that little later. Then there is a question on fetal anomaly. Maybe we have already discussed, and Dr. Premjit Chakraborty, who might have joined later. Dr. Chakraborty, we haven't had any major concerns yet. There is definitely legitimate concerns because mRNA viruses do cross the placenta, as there are ACE2 receptors in the placenta and decidua as well. So there could be chances that it is teratogenic, but data so far is not supporting any enhancement on top of the background risk for miscarriage for any woman. And obviously, COVID infection in the first trimester is not an indication for termination. Dr. Sandeep Tripathi is asking if someone is, it's written in Hindi, if Dr. कितना प्रतिशत महिलाएं अफेक्टेड हुई कोविड से जो कि गर्भवती है, अगर कुछ जानकारी मिल सके. What percentage of pregnant women have been affected so far? Does anybody have that data?
I don't know.
No. Okay. Now, let us just move on with the discussion that suppose someone comes to you, Dr. Shaha, at 38 weeks, testing positive. Now, will you deliver them sooner?
No, I won't be delivering them sooner because they are positive. If the patient is asymptomatic, definitely we will carry on the pregnancy till she comes out of her isolation period. In the meantime, we have to reassure the patient that during this time, if she goes into labor, we can allow her to go into labor, have a normal delivery. And if there is any indication to do a cesarean section during that emergency time, we will be definitely doing it. And she doesn't have to worry that because she's COVID positive, we will be postponing her treatment or we won't be doing her treatment. But if she's positive during that time, we won't do any routine procedure like an elective cesarean section or elective induction of labor.
So are you doing RT-PCR still? There have been some conflicting guidance in the last 2-3 days. One is saying RT-PCR, one is saying it's not mandatory. What is your practice now?
Now, the thing is, I practice in corporate hospitals. Okay, so here I won't say the protocol. Here, what they want is that all patient who is getting admitted in the hospital should have a RT-PCR negative. The reason behind what they are placing is the safety of the staffs also. Now, if we go by the ICMR guideline, which was issued in 10th of January 22, pregnant women in or near labor who are hospitalized for delivery should not be tested unless warranted or symptoms develop. Now, it is very difficult to say what is the word warranted means. It is justified and necessary. So you can always justify why you are doing it. Maybe not fully on the basis of the benefit of the patient, but sometimes the benefit of the caregivers also. So ideally, we shouldn't be doing it. But again, there are clauses. I am not very sure about what's going on in the government hospitals, to be honest.
Also, it is interesting to see the ICMR guideline, which says the pregnant asymptomatic woman can be tested if they come in contact. Now, who is not coming in contact these days? It's there everywhere. So you can justify your testing in any case. Now, coming back to that 38-weeker, obviously we are worried about vertical transmission. As we know, for all cell-mediated viral infections, in the early pregnancy, the chance of vertical transmission or transplacental transmission is smaller, but it is more severe. That is why the fetal affection have happened when the organogenesis time is also happening. Now, towards the end, vertical transmission incidence is higher, which can infect the child. So, do you think vertical transmission is a significant concern here, and what is the incidence?
Again, now the data is emerging that there are cases of vertical transmission, and they're saying is around 3 to 4% of vertical transmission if it is in the 3rd trimester pregnancy. But whether there is any clinical significance of these vertical transmissions, I won't be able to say. I think the ball will be going more towards the pediatrician, that how they are dealing with this kind of patients and with the babies. So Shomo will be the right person to clear our doubts about it.
Now, as an obstetrician, will you encourage the mother to breastfeed?
If the mother is asymptomatic, yes, definitely we'll be encouraging the mother to breastfeed. As if we go by the RCOG guideline, they're saying, yes, the mother can breastfeed, but when she's doing breastfeeding, she has to wear a mask, not to cough when the baby is with her, and do the proper hand hygiene. If the mother is worried about it, then she can either express the breast milk with a breast pump, and some healthy caregiver can feed the bottle with the breast milk. Yeah.
Right. Now, there is a statement basically from Dr. Kaushik Chakri saying elective procedures can be considered after 2 weeks of COVID-19 positivity in patients without comorbid conditions. Concerned doctors will decide regarding elective procedures, of course. Now, Indranil, will you retest them who have already tested positive with COVID?
No, if we go by guideline, we don't have to retest them. And after the test is positive, after 7 days or 10 days, we can jolly well treat them as a asymptomatic patient or not spreading the infection. So I won't be retesting it as by guideline.
Continuing with the breastfeeding issue, I now move on to Dr. Shomokanti Panda, who is our esteemed pediatrician this evening. Shomo, suppose the child gets delivered when the mother is COVID positive. Then will you let them breastfeed? Will you keep the child in the same room with the mother?
Suppose the mother is positive, but the baby is still RT-PCR negative. Baby has been tested within 48 hours and the baby is RT-PCR negative. In that case, we'll definitely try rooming in, but it's not bedding in that is advised. And during breastfeeding, mother will always wear a mask and we'll try to keep the bassinet at least 6 feet away when the mother is not breastfeeding. But if both are positive, then we can jolly well go with the same.
So it's important to note that both obstetricians and pediatricians are actually encouraging breastfeeding. So please do take this message home. There is no contraindication to breastfeeding. Yes, there are certain cares that must be followed. Now, Shomo, what signs and symptoms do you follow which tells you that this particular child has got COVID? Because there is a lot of overlaps, fever, rash. It happens everywhere. So how do you know that this child is COVID?
Basically, the symptoms and signs, they vary widely between the neonatal age group and the childhood age group. Neonatal COVID is not much defined as it is defined in the adult population or in older age group of children. In neonatal COVID, it's more of a generalized illness like generalized lethargy, refusal to feed, like that. Yes, they may present with respiratory distress or shock or multi-organ failure, but in most of the cases, the features is like generalized sepsis and all. And in pediatric age group, apart from the symptoms in the adulthood population, like respiratory distress and all, important finding is GI symptoms. Diarrhea and vomiting, they are one of the predominant symptoms in the childhood age group. And rashes, all types of cardiovascular manifestations, including myocarditis, pericardial effusion and all, coagulopathy, shock, multi-organ failure, they may present with that.
So do you recommend any particular treatment for these affected children?
Basically, that is dependent on the stage of the disease. We divide pediatric COVID into 4 stages. First is asymptomatic. Then in the symptomatic group, we divided them into mild, moderate, and severe. In the asymptomatic group, when they have been tested due to some contact issue or some incidental finding, nothing is needed. And mild, moderate, severe, in milder cases, saturation is always over 94%. There is no respiratory distress. Only thing that they present with cough and cold, rhinorrhea, sore throat, like that. We need nothing much except paracetamol and proper hydration. And no investigation is needed. Up to the case is mild. Up to when the case is mild, no investigation is needed. Investigation is needed when the case is moderate or more. In the moderate cases, respiratory rate is high, saturation varies between 90 and 93, and in severe cases, saturation is less than 90. They may present with shock and all types of severe symptoms, including COVID-MIS-C and COVID-Kawasaki, that I will
we'll come to that
later.
Meanwhile, let me take a question. Dr. Kaushik Chaki has asked, Dr. Panda, are you experiencing any difference of symptoms in children this time compared to the previous waves?
Yes. Omicron, mostly they are not causing severe lower respiratory tract infections or severe symptoms, severe shock, severe ARDS. Not like that. Omicron is mainly causing the upper airway symptoms, including sore throat, rhinorrhea and all. Probably Omicron is not that much severe in pediatric age group.
Right. Okay. So the symptoms that you have explained are also expected in the slightly older groups, or neonatal pediatrics are totally, to some extent, different? What would you say?
Different. They are different. They are
They're
different.
different.
Yes.
Yeah. Okay. What about vaccinations? I mean, there has been recommendations that 15 to 18 can be covered. Are we seeing anything on the horizon for the younger age groups?
Yes. Covaxin, actually, they have got emergency use authorization starting from 2 years to 18 years. So in near future, they will reduce the age group probably. And in America, they are using Pfizer BioNTech vaccines from 5 years onwards. Moderna is also there. In India, Jacob D has also got emergency use authorization.
Okay. Now, we have heard of Kawasaki syndrome before, and recently we have heard about MIS-C. Of course, Kawasaki is also a multi-system inflammatory disorder, as far as I know. Is there any overlap with COVID? Why are we hearing them more and more?
Yes, MIS-C, multi-system inflammatory syndrome in children, and its counterpart is multi-system inflammatory syndrome in neonates. So how can we diagnose that? We need basic 3 days fever associated with shock, coagulopathy, cardiac involvement, including myocarditis and aneurysms, GI symptoms. GI symptoms is very much common. There is much overlap with MIS-C and Kawasaki, but Kawasaki is a bit milder form. Kawasaki is much more commoner in the Asian population, especially in Japan, India, these things. But MIS-C is much more prevalent in the Mexico and the around populations. And basically these coagulopathy, shock, lymphadenopathy, this kind of features are much more prevalent in the MIS-C group. But coronary aneurysm, that is common in COVID Kawasaki, whereas myocarditis, myocardial ischemia-like features, they are much more common in MIS-C. So there's much overlap. Treatment varies a bit.
Right. Going back to basics again. Now, we are trying to persuade the general population to wear masks. What is your experience with children? How compliant are they in your personal experience?
Almost all of them are using, almost all of them are basically trying to use mask on their babies, even if the baby is 6 months or more.
Right.
Basically, what WHO says, we definitely try using mask in 5 years or more if they can follow the do's and don'ts of mask. And after 12 years, we'll definitely start using. In between, if they can follow all the do's and don'ts, they can use. But no need to use it before 5 years of age.
Now, we keep on saying fever and rash for many things. Now, can you clinically separate COVID rash from other infections?
Yes, basically, with the clinician's point of view, our first aim will be to differentiate the rashes, which will be very much devastating in nature. With this COVID everywhere, we should not forget the rashes of scrub typhus, dengue, meningococcemia and all. And regarding COVID, they may present with maculopapular, vesicular rashes, all types of articular-like features, ischemic lesions over the extremities, mainly over the feet, and those liver reticularis or the mottling-like features. These things are common in COVID rashes. So we should differentiate those from the commoner rashes. Basically, it's not important to differentiate between two common viral exanthems. I'm not saying of measles, but we may not differentiate clinically in between, suppose, erythema infectiosum and roseola infantum. No need of it. That will go by anyway. But we shouldn't miss the severe kind of rashes, including toxic shock syndrome, staphylococcal scalded skin syndrome, and all.
Same question if I ask for respiratory distress. Is there anything different with COVID infection?
Basically, before going into the details, respiratory distress is common to all clinicians, but it's a bit difficult to find out respiratory distress, especially in the neonatal populations. In the premature infants, because of their much more pliability of the chest wall, retraction is much more. Upper lower chest retraction, xiphoid retraction, nasal flaring, and grunting. These things we should look for, not the respiratory rate cyanosis this way. Premature infants, respiratory distress picking up is a different spectrum. And in term units, then respiratory distress, the respiratory rate cyanosis, these things will come into later.
Right.
And
I give you a little break when I go to Dr. Saha. There is a question in the YouTube. Dr. Saha, if a pregnant woman is tested positive and undergoing LSCS after 2 weeks, will you advocate testing before procedure?
No, we are not advocating testing before the procedure.
Right. Okay. Back to Shomoy again. Mental health issues. Dr. Kaushik Chaki has asked this question. Mental health issues in children during these difficult times.
yes, they cannot go to the playground. They are not attending schools. So definitely depression and anxiety and all kinds of mental health issues are very much common in this era. And one more thing, they are having obesity. And the excuse is very much common. They are not attending the playgrounds and school, but we can definitely advise them to exercise at home itself. And regarding depression, we can definitely arrange some Zoom meeting like things with their friends and their schoolmates. And definitely psychiatrist and psychologist will be of our help.
Dr. Shankarnath asks, in third wave, any atypical symptoms different from earlier waves? We have kind of touched on this. If you could just briefly mention again. In the third
Yes.
wave, any atypical symptoms different from earlier waves?
It's not rather atypical. We are getting basically much more milder symptoms now. Upper airway tract infections are much more common than the lower airway tract infection. And till date, I have not found any COVID death in the third wave. Obviously, I've seen two to three patients ventilated, but no death till date. But in the second wave, the course was much more worse.
Now, we are getting inundated with various guidelines. As pediatrician, you may be able to cope with all those for pediatric population. Now, I have a question along those lines. Dr. Saurabh Mukherjee asks, what are the practical guidelines that should be followed when an infant and his or her mother both are affected by COVID? What are the danger signs to look for? And if at all, any investigations and medications? So quite a few components there in these questions.
Well, first of all, there is no such specific anti-COVID medicine. Only thing is, most of the cases, it's symptomatic management. In mild COVID cases, the only thing we should do to relieve fever with paracetamol and hydration. But when the course is much worse, in the moderate to severe age group, we should use oxygen and all kinds of breathing support to keep the saturation more than 94%. Then we should start antimicrobials, not as an anti-COVID measure. In the moderate, we should ask 4 questions before use antimicrobials in any case. With all the signs and symptoms, we'll try to locate our probable focus, then our working diagnosis, then presumptive organism according to our working diagnosis, and our local sensitivity pattern. I'm giving an example. Suppose the patient has presented with cough, cold and respiratory distress. So our probable focus is lung, our working diagnosis is pneumonia, and probable organism may be Streptococcus pneumoniae. So according to our sensitivity pattern, we may provide amoxicillin here that way. And in severe cases, we should start steroids and low molecular weight heparin. And if the case goes into the MISC stage or in COVID Kawasaki case, then the scenario is different. We may start using IVIG, methylprednisolone and all, aspirin and all.
Now, I have a question from a reporter, which has been answered by Dr. Kaushik Chaki. Now, reporter Shwandip Tripathi has introduced himself and said, can you tell me that how many percentage of children affected due to Omicron or COVID, if any data is there? Dr. Kaushik Chaki answered back saying, dear Shwandip, no definite data is available till date. Now, can you cast any more light on that?
No, we are not doing any genetic sequencing here. So we cannot know how much percentage of them are Omicron positive.
Right. Okay. Again, a question to you. Positive. Yeah, sorry. Go on.
RT-PCR is not equivalent to Omicron positive.
Absolutely. So what are the facilities of gene sequencing? Just to inform our folks, if someone asks for gene sequencing, an affording patient, suppose, wants to know, do they have an option?
I don't know actually.
Dr. Chaki. Maybe Dr. Chaki can answer that? Or Shankar?
Can you come again, Kanchan?
He will come back later. Okay.
No, I asked that, can you come again with a question?
Oh, sorry. The question is, if an affording patient wants to have gene sequencing done to know whether he or she has got Omicron, do they have an option?
At present, no. In our state, at present, no. It's not by the choice of the patient. It's as per some government guidelines and also accessibility and availability. Right now, in the state of West Bengal, there are only 2 centers who are doing genome sequencing. And
Dr. Mangolik is raising his hand.
But everybody is not as lucky as Sridhar.
Dr. Arun Mangolik.
Can I add something here, sir?
Good evening. I just wanted to add, I absolutely agree with what just the previous speaker said. The only issue is the government is not allowed this to be done at the private sector. Only it is done at government centers, and they do it randomly from the RT-PCR positive samples they get. So nobody, even if he affords it, the option is not available to that particular person.
Right.
Simple as that.
Absolutely. Now, Dr. Shah, there is a question for you. Dr. Kaushik Chaki wants to know if there is any, if you have any idea about incidence of mucor in pregnant women, and if so, what is the line of management?
No, in our experience, we haven't seen any instance of mucor. And if it happens, obviously we refer to Arjun Dashgupta.
Absolutely. I haven't come across any pregnant woman when mucormycosis was a big news. I haven't come across any pregnant woman either. Okay. Shomo, you wanted to say something?
Actually, Kanchan,
yeah?
The idea of asking the question is that, yes, obviously the patient do well to go to an ENT, but should the pregnancy be terminated if mucor is diagnosed?
It depends actually. Now, if it's in the early non-viable state and you're giving too much of antibiotics, and we'll see, that is have effect of the on the baby, then obviously we have to think of termination if the risk is more to the baby. But again, it has to be an MDT before taking a decision. And if the baby is viable, in that case, probably it will be better off to give steroid and deliver the baby and then had a full-fledged treatment for the mucormycosis. It completely depends upon the gestation of the baby. Am I clear, Kaushik?
Crystal clear. Crystal clear. Thank you.
Absolutely. So, Shomo, another question for you from Dr. Orgho Chatterjee. how we monitor for development of coronary aneurysm in children recovered from MISC.
Yes, coronary aneurysm is much more common in basically COVID Kawasaki. It's not MISC. MISC, we get myocarditis and pericardial effusion much more. And coronary aneurysm will test with echocardiography at least 3 to 4 times. First, during the treatment itself, then 1 to 2 weeks after the completion of the treatment, then at least 6 months later, and then at the end of 1 year.
Right. Okay.
And
now
there is basically specific measurement of coronary aneurysms, and we'll continuously monitor the development of aneurysms and possible rupture. If it's more than 8 millimeter, then only we'll call it as giant aneurysm. Otherwise 4 to 8 millimeter is moderate, and in giant aneurysm, they may cause much more complications.
Fantastic. Now, next question from Saurabh Mukherjee, and I guess any of the faculties in the Zoom can take this one. Please discuss how to clinically differentiate between Delta and Omicron variants, as genome sequencing is not possible for all. Is that possible at all? Dr. Mangaling is shaking his head.
No, not possible, sir.
Not possible. Right. Kaushik, Chaki, do you want to add in?
Can I add something here?
Yes, please.
We can, the best way to go ahead, we need to look into the fact that Delta is far more dangerous. So if a patient continues to have fever, and that's so high fever for more than 4 days, then our antenna should be high up, that this is unlikely to be Omicron, which should have resolved by 3 to 4 days, and the fever is continuing, so we should have our antenna up, and then we may consider this may be Delta also. In those situations, we go into the precautions which we used to take earlier on, like monitoring the home monitoring of the oxygen saturations, 5-minute walk test for adults, even for older children. And if required, we need to hospitalize, consider steroids, consider anticoagulants, and all those blah, blah, blah treatment, whatever it was. So that is something which is very important. And if the fever continues for more than 4 days, we have to be very, very careful.
So with Omicron, what are the common complications you are getting, Dr. Mangaling?
Well, Omicron, so far, I've been very lucky to have almost the vast majority of patients just recovered within 3 to 4 days, practically with almost zero complications.
And the hospital admission rates?
None. None for kids. I mean, I'm taking children, so none for children.
None for children. None for
small
children.
thing, yeah. But
so you are working in a hospital setting. Admission rates?
It's very, very high, at least 100 per day.
Right, and all RT-PCR positives?
No, this 100 is total COVID and non-COVID beds.
No, what percentage of RT-PCR positives in the current wave getting admitted? Do you have any idea? I mean, during Delta, we were getting a lot. Of course, the children were not that many affected.
Today, we have 17 patients with COVID in our COVID ward. We have COVID and non-COVID positive patients.
Mm-hmm.
So in the COVID ward, we have 17 patients now.
Right.
Can I ask one question? I mean, I agree with Dr. Panda that there are 17 patients, agreed. But are they admitted for COVID treatment, or are they incidentally COVID positive and they admitted for something else?
No.
Because that is a very big issue.
Incidental positive cases, or those cases who are mild in nature, they are going in the home isolation. Only thing is, they have been admitted due to some issues. Almost 3 to 4 of them are being ventilated.
But are they due to COVID pneumonia?
No. They may present with something else, but incidentally, many of them came to be positive.
So the point remains that the admission is primarily because of some other illness, and they are incidentally, coincidentally COVID positive.
Yeah.
Right. Okay. So there is some overlap basically. Now, a question from Dr. Argo Chatterjee. Child with COVID, tachycardia, out of proportion to degree of fever, can have cardiac sequelae later on. Any role of prophylactic beta blockers? Do you want to take
Heart rate,
this?
how much? Heart rate, how much?
Out of proportion, tachycardia, out of proportion to degree of fever.
First of all, we'll have to reduce the fever. Before going into the tachycardia, first of all, we will have to reduce the fever and take on the sepsis part. After that, if the patient is having heart rate at least 30 to 40 more than his or her baseline, then we'll definitely try with beta blockers. Otherwise, the child will go into heart failure eventually.
Right. Now I move on to the senior faculty present here, maybe Dr. Shankar Jha, Dr. Chaki, Dr. Arun Mangalik. There is a question from Mukta Mondal saying to the esteemed faculty, was the huge rise in mucormycosis a result of rampant use of steroids, or can we attribute it to the use of contaminated oxygen cylinders or humidifiers?
I think Shankar can take that question.
Shankar?
Yes, Kanchanda, thank you. I think both combined. As in the earlier waves, we needed to use more oxygen and more steroids. That's why the incidence of mucormycosis was a bit higher. We don't know what is the contribution of both of them, but definitely steroid use was a part, and we don't know that there were so many emergency cases and people were so busy with the wards that wards were full, ICUs were full, and very few people needed that they felt that they must change the water reservoir for the oxygen. So it is somewhat a very good question, but we need to find out the answer. Maybe some ENT surgeons would highlight more, but
So
I think both have contributed.
It's a combination of factors. Another very good question from Dr. Shobhan Das, as always. What are the danger signs and symptoms of a COVID positive toddler or neonate that parents should know about when they would call promptly? This is a very practical question. Shomo?
Saturation less than 94% and the respiratory rate more than the age appropriate rate. Like less than 2 months, it's 60, cutoff is 60. 2 months to 1 year, the cutoff is 50. And more than 1 year up to 5 years, the cutoff is 40. So any respiratory rate more than that, and otherwise the features of generalized shock and multi-organ dysfunction like that, rashes, conjunctival redness, this thing will be ominous.
Let me just go back to basics again. Now, pharmacies are running out of stock with vitamins. Different types of vitamins are completely out of stock. What is your recommendation for the parents?
Nothing needed.
Nothing needed. Dr. Mangalik, you concur. Yes.
Yeah, absolutely. Don't bother about the vitamins.
Right.
Just a normal, healthy family diet would be good enough.
Lovely. Now, Indranil, in this time when people are missing a lot of appointments, we do face a lot of important screening tests and others, particular ultrasonographies being missed. Now, suppose a woman has missed Down syndrome screening test at 12 weeks, having had COVID infection. How do you advise them?
If they miss the first trimester screening, then what we do is to advise her go for a quadruple test, okay, around 16 weeks to 20 weeks. And if they want a more definite test, because we know the sensitivity of quadruple test is less than the first trimester screening, then if they can afford, they can do a NIPT or NIPS, whatever name we call it. And the cost is approximately 10 to 13,000 rupees. And you are expert, so I'll ask you to give a opinion about the first trimester screening if they missed it.
Thank you so much. I mean, and not much to add here. To be honest, we have a range of options for the first trimester, for second trimester. And whenever we get the best opportunity, we do it. Gold standard currently is a combined test, which is a combination of NT scan and double marker test at around 12 to 13 weeks. If somebody does not manage to get it done, then there are other options. We do not want to go too much into obstetric discussion when we have a mixed population here. So we are coming towards an end. So Indranil, your take-home message for the pregnant women?
We will divide into the trimester wise. If the infection in the first trimester, we'll reassure the mother that there is no evidence of increased congenital malformation to the baby, and there is no indication of termination if they have infection, and they should judiciously use the medicine. Paracetamol will be absolutely fine, no use of antibiotics unless necessary. In the second trimester, the risks are low. Keep safe and be at home and follow the isolation rules and the precautions. If you are worried, we can do a growth scan after 2 weeks. You recover from the infection, and again carry on with your normal vaccines whenever it's feasible. If there is slightly delay in the antenatal care, nothing to worry about. In the third trimester, we are saying that if you have an infection, that doesn't prevent you to get any kind of emergency care. If emergency cesarean section is needed, if you are positive, we will be definitely doing it, but we won't be doing any elective procedure during the isolation period. And the rate of transplacental transmission is low, and it will affect the baby, and you can breastfeed the baby, and you can be with the baby even if you have COVID infection. As Shomo mentioned, that if the baby is negative and the mother is positive, we'll take some precautions. If both are positive, the mother and the baby will be together.
Excellent. Same question to Shomo. What's the take-home message for the parents?
So until and unless the case is a milder cases, go with paracetamol, hydration, and regular healthy family diet with regular exercises. And if the case is much more severe, contact with your family physician or pediatrician or attend any emergency. Otherwise, it's the COVID appropriate behavior of the parents or the caregiver that is much more important.
Right. Excellent. Now, unless there is any questions, we will come to a close very soon. But before that, I just want to make an announcement that next week, West Bengal Doctors Forum has organized another very useful CME that is a discussion on mental health issues among doctors and healthcare workers during this protracted war against COVID. Very, very important issue. Right. Dr. Mangalik, do you want to make any closing comments?
That's fine. Dr. Shomo has been superb with his answers. The only comment I would like to make to the public, because I believe we are having a lot of non-medical people around in the audience, maybe in the YouTube or other, that we should not panic about the pandemic. Well, it is there. We should stick to our COVID appropriate behaviors, the masks and sanitization and distancing, the mask being the most important, but we should not be panicking. I mean, let's not make it a panicdemic. Let it remain a pandemic, which will soon become an endemic thing. So with this message, I mean, it's nothing over our head. We've gone these 2 years. We've learned a lot. Sometime in 2 years ago, we were behind, we were back to the wall. We never knew anything about it. Now we are much more educated about it. So we know what to do. We are far better off. Thankfully, if another mutant strain doesn't come up, which becomes much more fatal, which is highly unlikely going by what the natural course of any virus is. The virus will try to survive. So if it has to survive, it has to keep the host living. If it kills the host, the virus dies. So if the virus has to survive, it has to go to a less fatal mutant. So hopefully, if that doesn't occur, maybe we may see the end of this pandemic in the near future. That's all.
Oh, excellent. So we are finishing on a very positive note. I must thank Dr. Shankarnath Jha, Dr. Kaushik Chaki, Dr. Sanjay Hom Chaudhary, and Dr. Arun Mangalik to add their valuable inputs here. and for having organized this whole event. We did have technical support from Sunil and Dr. Lakkar, Mr. Lakkar, Abhishek. Anyway, thank you all again. And thank you those who have been with us this evening and posted questions or even just listened to us silently. Thank you once again. Another question posted from Mr. Saurabh Mukherjee. Recent FDA approval of 2 antiviral drugs named in mild to moderate COVID, both in adults and neonates, especially those going to severe COVID also. Please discuss this update. 2 antivirals, sorry, I'm a gynecologist, I can't pronounce them. Etesevimab and Bamlanivimab. Any idea?
Basically, we don't have any guidelines regarding that till date.
Right. Okay. All right then. Thank you all again. So look forward to seeing you all again next week on mental health issues. Thank you all.